Okay, I guess this is the big day. It's the first CIDE seminar, so welcome everybody. And I would like to thank Franco Peracchi who has accepted to talk, to speak for this first seminar. We will talk about a very interesting topic, which is estimating the prevalence of COVID-19, which is something very important from many perspectives, also for economic policy. So of course, the samples are not, the tests are not randomly done, and there are some issues here, and he will tell us about these. Franco doesn't need to be introduced. I met him almost, he doesn't remember, but I met him almost 30 years ago in Bressanone. I will never forget. And it is always a pleasure having to do with him. And believe it or not, today you will listen an architect talking about COVID-19, which is something astonishing. So I guess it's time for Franco to get in. Thank you very much. And go ahead. Thank you.
Okay, thank you, Gabriele, for the introduction. And thanks everybody for coming to this webinar. What I want to talk today, is joint work with Daniele Terlizzese at AF. And what we try to do in this paper is to present or propose a quick and hopefully useful way of estimating the prevalence of the COVID infection. And we use Italian data to illustrate. So let me start by saying that knowing the prevalence of the infection in a population, as Gabriele was mentioning, is very important for public health. But unfortunately, all we know about is the fraction of people who test positive. We don't know the fraction of people that are infected. And this fraction that we can measure, those that are positive when tested, is likely to underrepresent the asymptomatic or those that show very, very mild symptoms that might not even be noticed. Now, to avoid this bias, the bias being in measuring the true prevalence rate using the fraction of positive cases, to avoid this problem, several countries have decided to start large population surveys. Well, these surveys are a good idea, but I'm afraid that they have problems of their own because number one, they're costly. Number two, they are complicated to carry out. Number three, they're going to be plagued by refusal to participate. And they take time to complete. So we think that there is some room for something, let's call it quick, perhaps less accurate, but definitely quick way of inferring from the available information something useful about the prevalence of the infection from data that are readily available. This is what we try to do here. Okay, so two concepts of prevalence with somewhat different meanings and usefulness. The first is the concept of point prevalence, is the fraction of people who at a given point in time are infected, okay? Then we have another concept of prevalence, which is the concept of period prevalence. And this is the fraction of those who have been infected during a given period. In particular, the fraction of people that have been infected since the beginning of the epidemics. So it is the fraction of people who have been ever infected, okay? Point prevalence is useful to monitor the risk of transmitting the infection. The rate of diffusion of the infection depends on how many infectious people are around. On the other hand, the period prevalence measure could be useful for reporting purposes, and 1 minus period prevalence is essentially measured the fraction of people that have never been infected. And so it's gonna tell you what is the fraction of the population at risk of being infected. There is a nice paper by Chuck Mansky and Francesca Molinari forthcoming in the Journal of Econometrics that focuses on period prevalence. Here, we focus instead on point prevalence. So let me begin with some definitions and assumptions. We assume that a person can be infected only once, that he is infectious as long as he is infected, and when the person recovers, no longer infectious. We measure time in days, and we assume that the population is constant, which is like mortality rates are non-zero, but are rather small, and we don't take into account births and these kind of things. So the key random variables in our setting are ID, which is a binary random variables equal to 1 if a person is infected, I for infected, on day D, okay? So time is in days, indexed by D. And we are interested in the probability that ID is equal to 1. This is gonna tell us what is the fraction of people in the population who are infected on a given day D. These people, by the way, it's important to notice that are not new infected people. They might have become infected some days ago, and they are around with their infection and transmitting the infection, of course. The second random variable is a TD, is another binary random variable equal to 1 if a person has been first tested on day D. T for tested, but not tested in general, first tested. And then the third random variable is denoted by P. So PD is equal to 1 if a person has first received a positive test result on day D, okay? So we are assuming here that nobody is tested more than once, and we are assuming that the test results are immediately available. Both assumptions are not realistic, but we will discuss some simple data transformation that are helpful in trying to come close to these assumptions. One key implication of this assumption is that if you know that someone tested positive in a given day D, then you know also that that person was first tested on that day, okay? So let me drop the time suffix.
Franco, sorry, just to see whether this way of posing questions works or not. It's a silly question. So
sure,
ID is non-observable, while TD and PD can be observed, right?
Exactly, yes.
Okay.
Yeah.
Okay.
No, that's right. We observe TD, whether a person is tested or not. We observe whether a person is positive or not after being tested. We don't observe whether a person is infectious or infected. Yeah. Okay. So drop time. Then, by the law of total probability, we can write down the probability of being infected as the probability of being infected, the condition of being tested, times the probability of being tested, plus the probability of being infected if not tested, times the probability of not being tested. What we observe here? We observe the probability of being tested and the probability of not being tested, which is just 1 minus. We don't observe the probability of being infected, condition of being tested or not being tested. Therefore, we cannot reconstruct the probability of being infected from the data alone. We need some extra information, okay? Now, to gather this extra information, we can rely on a number of sources. One source of useful information is the operational properties of viral test, or what I call viral test is this kind of nasal swabs or nasal pharyngean swabs. What we know from the medical literature is that the probability of false positives or type 1 error, so here is the probability that someone is declared positive conditional on being tested, t = 1, and not being infected, I = 0. This probability, there is a consensus that is negligible. So we treat this probability as 0, okay? Simplifying assumption, but not too far from what most medical literature would argue. What is not 0, on the other hand, is the probability of false negatives or type 2 error. So is the probability of not being positive when, after being non-infected, the probability of ending up positive in a test, t = 1, when you are infected, or not being positive, p = 0 in a test, when you are infected. So there is a consensus that beta, these false negatives probability, is non-negligible, and is largely the result of how tests are carried out. In particular, samples may be collected too early or too late. They might be contaminated, or they might have been sitting in the refrigerator waiting to be examined for a week or even 2 weeks, okay? All this might lead to type 2 error, false negatives. No evidence of being positive when in fact the person is infected. Now, for this beta thing, the available literature suggests a range that goes between 2% and 40%. And often this range is narrowed to something between 10% and 30%. So it's not a small probability. Now, under the assumption that type 1 error probability is 0, we can show that the probability of being infected, the conditional on being tested, is just a rescaled version of what you observe, the probability of being positive, conditional on being tested. Rescaling is 1 minus the probability of type 2 error, okay? So if you want, in testing jargon, is the power of the test, 1 minus beta. Now, it's a useful result because it shows that what we are interested in, one of the two objects that we are interested in, the probability of being infected if tested, is a function of two quantities, one of which is observable, and that's the probability of being positive conditional on being tested, and the other one, beta, is a quantity on which we can make some kind of guess based on medical knowledge. In particular, if there is no type 2 error, beta is equal to 0, you see that the probability of being positive coincides with the probability of being infected. There is no error, and the two objects are the same. Now, the other piece of information is the following. Who are we taking swabs from? Typically, we take swabs, the medical people take swabs from, let's do one thing. Gabriele, are there any questions on what I discussed so far?
So far, no questions.
Okay. All right, so I'll move on to the next, which is the infection rate among the people that are not tested and among those that are tested. So from what we know from the practice of testing on the field, swabs are mainly taken from those that are at risk or at higher risk of being exposed to the infection, or even have very visible signs of being infected. So it's plausible to assume that the probability of being infected is higher among those that are tested than among those that are not tested, okay? Is equal or higher. Now, if the tests were random, which they are not, the two probabilities would be the same, okay? But we have all kinds of evidence suggesting that, in fact, the probability of being infected is higher among those that are tested. So let's assume that the probability of being infected among those that are tested is positive, okay? And let's define the ratio between the two probabilities. Numerator, probability of being infected if not tested. Denominator, probability of being infected if tested. So this lambda can be thought as the way in which you rescale what you observe in order to figure out what you don't observe, okay? If you could know what lambda is, that would be useful. What we know is that lambda is between 0 and 1, probably strictly greater than 0 and strictly less than 1, because we know that there is a bias towards the risky people in the testing practice. Putting together these two sources of information, one coming from the operational characteristics of the test and the other coming from the way in which in practice tests are carried out or swabs are taken, we get the result in the middle of this slide, namely that the probability of being infected is a rescaled and tilted version of the probability of being positive if tested. Rescaled by the power of the test, so 1 minus the probability of type 2 error, and tilted by the factor in square brackets, in which what you have is the probability of being tested, p t equal 1, plus lambda times the probability of not being tested, okay? If lambda was equal to 1, no bias in testing, then this term in square brackets would just be equal to 1, okay? Now, why is this useful? This result here is useful because it shows that the probability that we are after, the probability of being infected, is an increasing function of two things that we observe in the data, the probability of being positively tested and the probability of being tested. And is also an increasing function of two parameters, beta and lambda, for which we have some plausible range of values. Now, for beta, a plausible range might be from 10% to 30%. Lambda is from 0 to 1, so it's a bit wide. Let's see whether we can make something narrower, whether the range of value for lambda can be narrowed down a little bit. So here is useful to further distinguish between those that are symptomatic, S equal 1, S for symptomatic, and those that are not, the asymptomatic, S equals 0. We are assuming that the infection rate is positive among both, especially among the asymptomatic. So if you are asymptomatic, you might still be infected. And the key assumption here is that if you are asymptomatic, the probability of being infected is lower than among the symptomatic. So the ratio between the probability among the symptomatic and the probability among the asymptomatic, this ratio is greater or equal than 1. Then let's introduce some extra notation, and I think it's pretty much all in this paper. Small n is the fraction of people that are tested. Pi is the fraction of the population that is symptomatic. So is the symptomatic, is the rate of symptomatology, I guess, in the population. And P is the fraction of people of the population that are symptomatic among those that are tested. So is the symptomatology, I guess, rate among the tested people. Pi and P need not be the same, okay? Given what I said, the ratio P over pi should be this ratio that I call gamma should be greater than 1, because we take the view that those that are tested tend to be tend to have symptoms that are more evident than those that are not tested. So the idea that the sample may be biased towards the symptomatic corresponds to the assumption that P is greater than pi, or equivalently that gamma is greater than 1. As you see here, we rely a lot on ratios. We rely a lot on ratios because they are free of measurement units. They are unit free. And precisely for that reason, it might be easier to make assumptions about these ratios than about the individual elements. All right, now, among the tested cases, those that are subject to test, the probability of being infected can be written down as I do here. And this is just an implication of the law of total probability. Our key assumption is that if you observe someone with symptoms, the probability that the key assumption that we make here is that the probability of being infected is the same in the population with or without symptoms. S equals 0 means no symptoms, S equals 1 means symptoms, irrespective of whether the people are tested or not. So having symptoms is all that matters. You are tested because you have symptoms. So this, we think, is a reasonable assumption. In other words, let me perhaps repeat, if you observe the symptoms, knowing that someone is tested or not carries no extra information about being infected or not. An implication of this assumption is the relationship that you see next. And this relationship here, the probability of being infected given that you are tested, is one of the ingredients in our lambda ratio. The other ingredient is the probability of being infected among those that are not tested. And this can be shown to have this somewhat more complicated expression.
Franco, sorry, before we get lost into these ratios, do you have information for the tested people whether she or he had symptoms or not?
Well, we don't, but as you will see in the empirical work, we have this information for the municipality of Vaud, that you might remember is the first is a municipality where we had the first Italian real Italian death. That municipality was subject to almost complete enumeration at the end of February. So we have that information for that location.
Okay.
So we have now the two expressions that we need to compute lambda, and lambda, after simplification, is going to be this ratio here that depends on four quantities, which are n, the fraction of the population that is subject to test, gamma. So what is gamma? Gamma is going to tell us something about the bias implicit in the testing protocol. If gamma is 1, no bias. Gamma greater than 1, increase in bias. Then we have pi, which is the probability of being infected in the population. And then we have mu, which is the ratio between the probability of being infected among the symptomatic and the probability of being infected among the asymptomatic. If gamma is equal to 1, lambda is equal to 1. But as I was mentioning before, we can use information that is around to do a little calibration exercise. So the data from Vaud are publicly available. They can be downloaded from the web. And from this data, we find that the fraction of that pi is equal to about 7%. Pi is remember, sorry, I'm jumping ahead. Pi is the fraction of people with symptom. So only 7% of the people involved had symptoms. Okay. Mu, on the other hand, is 18%. If you want 20%, is a ballpark number. Then we set n to be 0.00004. So in percentage terms, at the end of June 20, only 0.04% of the Italian population is tested on a daily basis. Okay, so it's a small, relatively small fraction. Given these values, we can see how lambda would vary with a bias in the testing protocol. So the picture is this one. Mu is on the x-axis. Gamma, it looks like a y, but is a gamma. Gamma on the y-axis. The vertical line is mu set at 17.8. And what you see here is contour levels of lambda as a function of gamma and mu, going from dark green, corresponding to lambda equal 1, no bias, to lighter green as you move out in the, what is that, northeastern direction. Moving out in that direction, lambda gets smaller and smaller, which means that testing becomes more and more biased. So lambda small means high bias, highly biased testing protocols. Lambda close to 1 means hardly any bias in testing protocols. Any question on this? Maybe we can pause here and take questions if there are questions?
Hi, no, I don't see, no for now,
Okay.
Francesco.
Okay.
So I guess they will come at the end.
All right, so let's now discuss something that is a little bit of a detour, but might be helpful. Remember, I mentioned two concepts of prevalence, and I said that in this paper we focus on point prevalence. The question that we pose here is, from the data that we have, okay, the Italian data are largely for protezione civile. So when I say available data, I mean data from protezione civile. Can I recover both concepts? Only one? Which one? Okay. So assume that the population is of constant size, big N. Suppose that the infection lasts at most 2 periods. Okay. And suppose nobody dies. A fraction delta of the infected recovers after 1 period, and the other 1 minus delta fraction takes 2 periods, a little longer. So those that you see around currently infected, ID, people infected, here, there is a little abuse of notation, I guess, because ID is a binary random variable. Here, we are saying the number of the currently infected. So there is a little bit of notation thing that we should probably address. But so ID is the number of newly infected people on day D, I star. And those that were newly infected the day before and take 2 periods to recover. Okay, so is a fraction 1 minus delta of those infected the previous period or day. So in this way, with this notation, you see that point prevalence is just a fraction of those currently infected divided by the population size. So it's just the ratio of that of those that are newly infected to the population, plus 1 minus delta, the ratio of those that were newly infected the day before to the population. On the other hand, the period prevalence is obtained by adding up all these new infection rates, okay, from the beginning of the epidemic, which is D equal 1. So this is an important difference and is understandable. Point prevalence refers to a point in time. Period prevalence refers to ever being infected. So you need to know the sequence from the beginning of the epidemic of new infected people. Now, how about recovering from the actual data all these quantities? We need another piece of information which has to do with the number of people who just recovered in each period. This has a dynamics that is similar to what we have seen before. Those that just recovered today is a fraction delta of those that we became infected yesterday, plus a fraction 1 minus delta of those that became infected the day before yesterday, 2 periods ago. The total number of people that recover from past infections is obtained by cumulating the number of people that recovered in each period or in each day. What is nice is that what you can show is that the total sum of new infected people from the beginning of the infection is equal to the number of people currently around carrying the infection, plus the total number of people that recovered from the beginning of the infection or the epidemic to date. So the period prevalence is equal to the point prevalence, alpha D, plus the ratio of people that ever recovered from the beginning of the infection. So this is the link between the two concepts in the population. So, you know, if you know alpha and RT, and you know the population size, you can go back to period prevalence and vice versa, okay? But we typically don't have the population data because what we have are samples that are drawn from the population. And here, to illustrate, let's take the very simple case in which the virological test is perfect. So type 1 error is 0, type 2 error is 0. And let's also make a very simplifying assumption, just, you know, to illustrate that sampling is at random and see what we get. Of course, none of these assumptions is realistic, but they give us a tractable and useful benchmark. Actually, I must add that this random sampling assumption is of some practical importance because, as I said before, some countries are embarking in random sampling of their population. So, in each day,
Franco, sorry to interrupt you. I have a question which I think is interesting.
Yes.
Well, I think it's Francesco. He says that when we get data arrives with a delay. So different countries provide data with a certain delay. How would this affect the analysis that you are?
Well, good question. What we do is instead of working with daily data, we use a 7-day moving average.
Yeah, that's reasonable.
No, okay. It's not perfect, but we hope that reduces that problem.
Okay, thank you.
All right, so we have a sample, let's call it small n of D, tested, or people tested in day D. Call P sub D the number of people who test positive. The expected value of that number of people who test positive is just equal to the number of people tested on that day times the point prevalence. So an unbiased estimate of point prevalence is just whatever number of people you observe divided by the size of the sample that is drawn on that day. Okay. Now, for period prevalence, we need a little more. We need to know who recovered from past infection. If we know that, that's fine. It's pretty much the same as before. If we know if we know the number of people that from the beginning of the infection have recovered in our samples, we can divide by the population size. We get an unbiased estimate of the ratio RT over N. We add the estimated alpha to that ratio, and we get an unbiased estimate of period prevalence. Well, the problem is that this is not what the data tell you. Because to identify those who recovered from the infection, we would need a serological test to detect people that were infected in the past and recovered, and they are no longer infected today. A virological test would say, oh, these guys are not infected. But what you need What we need is whether these guys have ever been infected. And for that, a virological test is not enough. We need a serological test, which is not what the data tell us. So what the data tell us is perhaps out of those that are tested today, who recovers in the future? But what we need is out of those that tested negative today, how many of them have been infected in the past? That's something that we don't know. And remember, I made, for simplicity, the assumption that sampling is at random. If you have biased samples, things just get more messy, and but we think that the general conclusion remains that is not easy, or is probably very hard to uncover from the data that we have, the Dipartimento Protezione Civile, the period prevalence. So I have like 15 minutes, so let me talk a little bit about the data. The data.
Franco, before you start talking about the data, I have another question from the public. Let's say, since you have a lot of quantity ratio that you need to infer, and
yes,
for some of those you use virological information, for others you use the result from BO and so on. The question is whether you can use information that comes from other countries to narrow the bounds of your.
Yes. What I could do is use data from China instead of data from VO. That's for example, another example of a full subpopulation that was tested was that ship. What was the name? Anchored outside Yokohama, I think. Diamond Princess. Was that the name of the ship?
Yeah, that was Diamond Princess, yes.
Yes, yeah. So, no, that's right. I mean, any kind of information is welcome. And there is, the problem is that all these quantities are not universal constants. They are likely to vary from one population or subpopulation to another, depending on a variety of things that have to do with the composition of the population by, for example, age, or the composition of the population by socioeconomic status, or things like this, okay? So if this information is available, it makes sense to use it. And it could well be information coming from another country. Is this enough as an answer?
Yeah, I think so. Thank
okay.
you. Yeah.
Right. Okay, so here are the data that we use. The data are the ones that come every day around between 5 and 6 p.m. from Protezione Civile. We use the total number of confirmed cases and the number of confirmed new cases. We also use the total number of swabs. These two series, daily time series, are available from February 24. And then we use a more recent series starting April 19 that contains the total number of tested cases. Now remember, swabs and heads are not the same. Some people may be taken several swabs. For example, you need at least 2 swabs if you are to be discharged. So someone that first tested positive, then is hospitalized and then discharged, probably took at least 3 swabs. Medical personnel might take swabs every day. So the number of tested cases is the number of individuals that have been first tested every day, or at least that the difference, the daily difference between the value of casi testati is new people subject to test for the first time. The most recent date is actually today, but I've not downloaded the data yet because we are still probably an hour and a half from the release of the data. But after the end of the seminar, I'm going to download the data. So the most recent date is really yesterday, June 30. The definitions are the ones that are based on World Health Organization guidelines. And for the population, I take the resident population estimated from ISTAT as of January 1st, 2019. You know, it's not the most recent, it's not, say, January 1st, 2020 or March 1st, 2020, but I think that the differences between these points in time are small enough to be negligible. Now, the new confirmed cases, this is important, gives the number of subjects who first test positive, okay? Being first tested on day D doesn't mean that you first became infected in that date. I already mentioned that the number of swabs overstates the number of people actually tested because several people are tested repeatedly. So the duplications that this testing thing creates are hopefully being eliminated by the new series on tested cases. The other problem that was mentioned actually a little earlier was the fact that the timing between swabs and tests is not fully aligned. You might be taking a swab today, but then the lab that analyzes your swab may take easily a week or more, even 2 weeks. So all these has to be taken into account somehow. And to take care of this and to remove a strong day of week effects, we use, as I mentioned, 7-day moving averages. Then there is a thorny issue of errors in the data. There is a clear, obvious mistake in Lazio on April 24 for tested cases. And so we start our exercise with April 25th. But there are other little mistakes here and there. For example, let me go back. The series of total confirmed cases should be strictly increasing or hopefully non-decreasing. You know, when the epidemic is over or close to being over, you should see in some days no changes in the number of confirmed cases. It turns out for some reasons that are not really clear, sometimes occasionally you see that the number of confirmed cases today is lower than the number of confirmed cases yesterday. I don't know. So estimation. How much time do I have? 10 minutes?
10 minutes to 5, so maybe if we go to 5:15 or 5:10, it's okay. Okay, thanks. So we first estimate, let's think of to the ingredients that we need. So we need the fraction of positive among those that are tested. We need the fraction of those that are tested. We take a moving average of the elementary data released from Dipartimento Protezione Civile. Then for beta, we take between 10 and 30%. We widen the range, including from 1% to 50%. And for lambda, the range we take is from 1 to 99%. But the data from VO
suggests a narrower range between 10 and 65%. Here are some results for the things that we observe in the data, and these are reported for June 20. Okay, so 10 days ago. A fraction of those that are tested is 0.4%. Okay, so just to be clear, this is not the fraction of people ever tested. It's the fraction of people tested on June 20. Okay, blue means much lower than national average. Red means much higher than national average. So Campania is only 0.1%, but Emilia, Friuli, and Trentino Alto Adige is close to 1%. Then we have the fraction of positive among those that are tested, again on June 20. Lowest is Basilicata and Umbria. 0 means is not 0, is some small positive number, and I'm only reporting the first 4 significant digits. So Basilicata, it could be like 0.00001. Okay. From Umbria, on the other hand, is 0.0003. So is the second smallest. The largest are in the order Liguria, Piedmont, and guess where? Lombardy. So the triangle, the industrial triangle from your economic history course, you should remember the industrial triangle is where the observed infection rates or measured infection rate is highest. The fraction of positive among those that are tested. National average is 0.8%, close to 1%. Okay, so that's the table. Now, if you look at the probability of being tested, there is much less variation in the first column with numbers than in the second column with numbers. So where you see lots of variation is the probability of testing positive among those that are subject to test. And you might say, oh, there might be a correlation between those two quantities. It turns out that the correlation, yes, is slightly positive. Is that something like correlation coefficient of 0.08. Okay, so I would not say that, as someone says, that the probability that someone subject to test turns out to be positive is caused by a high testing rate. Okay, for 2 reasons. I don't see that correlation, and correlation doesn't imply causation, as we often say. So here is an example of how you can use the information on the observables and a range of values of the unobservable parameters lambda and beta to say something about the probability of being infected. These all refers to June 20, okay? And red is the range of more plausible values of lambda and beta, okay? Now, if you take all possible values, you go from 0 for the probability of being infected, or meaning a quantity indistinguishable, positive but indistinguishable from 0, to 1.5%. Now, 1.5% of about 60 million of Italians is not much, it's less than 1 million. And this is the largest, is the upper bound on the estimated number of people that walk around with infection. That estimate is going to be cut down by 1/2 if you limit attention to the red region. So that estimate goes down from about 900,000 to less. No, did I say 900,000? No, that's correct. 900,000 goes down to something between 400 and 450,000. That's the upper bound. Okay, you might say, oh, so few. Well, yeah, there are not that many, but I would say they are enough to create problems, especially in some regions. Okay, especially in some regions. Now, what I can do is to show you how things change. Yes.
Hello? No.
Yes, I'm here.
Okay, so I have a question from the public.
Yes.
Which is interesting, but I don't know whether you can give an answer or not. It's whether you can conduct the same type of analysis for a specific group of people, say by age or by regions or by.
Well, look, if Dipartimento della Protezione Civile was willing to give me those data, the answer is yes. But Dipartimento Protezione Civile only gives me aggregate at the national and the regional level. I don't even have casi testati and SWOT. I don't have casi testati at the provincial level. And I don't have casi testati and by gender or by age. You know, I wish I had, or I should say, we wish we had. Yes.
Okay, then I also have a question, I think. Let me see if others know. In the previous table, you had a range of prevalences for different value of lambda and beta for the June 20th, right?
This one. Yeah.
So I would think whether you have some sort of the evolution of, for
I'm going to show you.
Value of beta.
This is going to come right now.
Okay, great, thank you.
Any other question?
So far, no. Okay,
so the next table gives you what you have seen for some range, some combination of lambda and beta, okay? And here is a more graphical presentation of what you have already seen in a way, and you see the three regions in the industrial triangle, plus a little bit of Trentino Alto Adige. Okay, here, time series, okay? As Gabriele was asking. So, blue is the probability of being tested at the national level. The scale is on the left. So there is some change, but it's not much. And there are swings up and down, okay? What changes more in a very clear way is the probability of being positive conditional being tested. This goes down pretty much monotonically till June 10, and then it fluctuates around a constant value from June 10 to date. Okay, remember these are moving averages, so some of the daily fluctuations are taken out. Okay, so these are the things that we observe. The ingredients for the next picture, which gives the estimates, our estimates of the fraction of infected people around in each day over time. And you see three colors that corresponds to three different values of lambda and beta. Now, beta ranges is a 0.10, 0.20, 0.30, okay? And you might think that beta doesn't change through time. On the other hand, although we take a lambda here in this exercise as constant, there are strong reasons to think that lambda is not constant over time, but is probably increasing. Remember that in our case, increasing means that testing is becoming less biased through time. In fact, here is a way
I take this opportunity to pass you another question from the public, which says that quantities like beta or lambda, but I think mostly lambda, may be time varying.
Yes, I agree.
Another exogenous covariates.
Yes,
So,
I agree. Lambda is indeed time varying, and you see here that how lambda changes. So let me explain this picture. Here on the y-axis, you have the probability of being infected. I'm fixing beta to 20%. So I have really no reason to think that the probability of type 2 error is time varying. So I'm taking the probability of type 2 error as constant, okay, at 20%. So it doesn't change. So this picture here shows how the relationship between lambda and the probability of being infected changes through time. So you see that that relationship, that given our assumption is a straight line, rotates clockwise, okay? And the thin horizontal lines are drawn at probability of infected people at 15%, the first one, and 5%, the second one. So 15% probability, estimated probability of infected people is pretty much what we observe at the beginning of May. And the probability of infected people estimated around 5% is pretty much what we observe in the middle of June, 1.5 months later, okay? So this picture shows that there are two things going on here. One is that the relationship between lambda and the probability of being infected changes because other things change, like the probability of being tested, the probability of being positive if tested, etc. But lambda itself changes, okay? And lambda itself is probably gonna go, is probably going up through time, okay? So hopefully this addresses the concern raised earlier. That lambda is not constant, and I fully agree. Now, to decompose, to understand the changes in lambda, we might use the structural decomposition that I presented earlier. You remember gamma, mu, n, etc. Understanding what's going on there with those parameters might help figuring out how exactly lambda may have changed. Okay. All right. So this is this is. Oh, and finally, I would finish up with this picture here, in which I show the dynamics of the estimated probability of being infected for 3 different configurations of lambda and beta by region, okay? And what you see here is lots of fluctuations, especially the scale is different across regions, but so is the dynamics over time. And in some regions, especially small regions like Basilicata or Molise or Trentino Alto Adige or Valle d'Aosta, the behavior over time is definitely non-monotonic. And you see ups and downs, sharp swings, and dramatic declines that are just due to the very small number involved in these regions. In the regions where the epidemic has been more substantial, like Lombardia, like Piedmont, like Liguria, etc., things look much more like the national aggregate. So smooth decline that has to be interpreted properly because lambda might be subject to changes over time. So, conclusion. We show, I hope, I convinced you that there are readily available data out there that allow for quick estimates. Of course, if we had more detail, like by gender, by age group, by socioeconomic status, by education, we could say much more. we can say something we think is useful for point prevalence. Period prevalence is a more delicate thing, and as I argued. Then we applied our method to the Italian data, and we think that point prevalence may still be quite large in some Italian regions, and because of this, caution is needed in removing the restrictions on mobility. Of course, health authorities who may have more information that we have could use our framework and have more detailed and more informative estimates about prevalence. I think this is the end of my presentation, and I look forward to further questions.
Okay, thank you very much. It's been great. So first I have a question from the public that says whether your results are robust to space aggregation. That is, if you estimate prevalence on a national basis, or you estimate prevalence on a regional basis, and then you aggregate. Maybe
what we have is a nonlinear relationship, so the aggregation is going to complicate things.
Yes. Okay, thank you. I do have well, first I want to say something. After the end of the seminar, we should stay at least 5 minutes here for feedbacks and stuff like that.
Yes.
Because this is the first seminar, but it's not the last.
Yes.
So let me take the opportunity to say that we plan to have 5 to 6 or 7 events every year, and we hope that participation is going to be great as it seems has been today. I do have a question or a comment. I don't know. Let me see if I can explain myself. Basically, what you say about prevalence is that it is not a large figure. So it's around 1%, 1.508 or something like that. It's not a great percentage. And ideally, it would be nice to control everything. It would be nice to screen the entire population every day, which is obviously impossible, right? Mm-hmm. But one way of monitoring the population through testing is use an idea that goes back to Dorfman, which is pool testing. Pool testing means that we take the swab to many people, we mix them together, and then we test this mix. If we say we have a pool of 10 people and the test is negative, it means that all of them are negative, right? So, Franco, is fair.
I'm not sure I understand exactly what you're saying.
It's called pool testing.
Yeah.
You take a test from a group of 10 people, right? Mm-hmm. Then you have this swab and you mix them like a single test. And then you test this mixed sample that you have.
Oh, okay. I see what you mean.
Then, if it is positive, well, God knows how many people are positive in the group. But if it is negative, then you're sure that those 10 people are negative.
Yes.
And of course, the optimal dimension of the group, it's simple binomial algebra. And it's an increasing function, it's an inverse function of prevalence. So for example, if prevalence is say 1%, you can have a group of 11 people, right?
No, I mean,
if prevalence is 10%, pool testing doesn't work.
Is the same idea of the exact test for no effect of a policy, I think.
And well, if actually, I think in China they're doing it. People, especially from the statistical community, are sort of pushing for having this pool testing. But it seems that at the moment, this idea is not, this proposal has not been well taken by.
Do you know why this idea is not used?
I don't know. There might be some problems. There might be some problems because, for example, a further idea, I did some algebra on two-stage pool testing. So you start from a group of, say, 50, then if it is positive, instead of testing all 50, you test 5 group of 10, for example. In this way, as long as prevalence is not very high, say around 1%, you can have a tremendous gain in terms of screening the population and number of tests.
Yeah.
One problem could be that when you mix together, say, more than 5 to 6 swabs, the tests become less reliable. There might be some confounding effect. I don't know. This is technical from something which I don't really know. This could be an explanation, but and there are some sort of people for some reason they don't like to have their swab mixed with other people, the swab with other people that they don't know. I don't know why, but there's also this kind of resistance. So okay, are there any more questions?
No, I guess, Gabriele, going back to your point, what is crucial here is that the sample that you're drawing, which means those that you ask to be sampled and respond positively to your request of being sampled, that should be a random sample of the population. So you need to have a sampling design that takes people at random from the population, and then you want non-response to be random. If there is no response, has to be completely random. Non-response cannot be related to symptoms or being infected. Things like this.
That kind of bias into sampling, yes.
Yes.
There are other approaches that say that you need to test natural groups. I don't know what they mean, maybe families or something like that, but I'm not sure. I don't know. This I should get into more. Okay, I have another question. Which I just read. I guess between region spillovers are not taken into account.
No, absolutely, yes. This is our model. I mean, our exercise treats each region as an isolated island. Yes.
Okay.
No, I think that the spatial dimensions are of great importance, and this takes back to the previous question: what's going on when you aggregate from the regional level to the national level? Well, you should take spillovers into account, of course, but we don't do that here.
Okay, thank you. So I guess we are done with all questions. And I thought it was a great seminar, and as a first one, I'm very happy. Thank you very much again. And well, so keep following us in our YouTube channel, and we'll soon put the program for next upcoming events. So Franco, thank you again.
Well, and, yeah, let me thank CIDE, the organizers of this webinar series, and all that have been attending this seminar for their feedbacks and for their patience in listening to someone in this kind of awkward way that I'm afraid is going to be the future for many months to go.
Great, thank you very much. Well, we should special thanks to Francesco Ravazzolo, who was the one who,
of course,
really
yes,
to put up this kind of events. So we're all grateful to him.
Yes.
Okay, so
all right.
I guess the YouTube streaming ends here.